Parasitic infestations and protozoal infections is the topic of discussion in this video. Hello dear students, myself Dr. Maddineni Srinivas. Welcome back to my channel. So topic first one which we are going to cover is the scabies. It's a highly contagious infestation because of the itch mite Sarcoptes scabiei where hominis. It is transmitted by the personal contact and also through the fomites. So what is the pathogenesis here? Remember the itch mite, which is a fertilized female. Remember it's a female mite which is going to produce this. Scabies not male. This was a UPSC question. It penetrates the stratum corneum, creating a tunnel which is called as a burrow, which is a pathognomonic lesion. And normally patient is going to have 10 to 15 mites over the body at a given point of time, and the presentation is going to be with extreme nocturnal pruritus, and you can remember the distribution is going to be in the area of the circle of Hebra. And also important point is similar complaints in the history, in the contacts, and also in the family members. This is a very important history. And coming to the variants of the scabies, this is a recent question, very important to remember. Adult scabies, infantile scabies, and the most severe form, the Norwegian or crusted scabies. So adult scabies, the papules and burrows are going to be present on the circle of Hebra, and adult sebums antiscabetics, that is the reason why face is going to be spared in the adult scabies. And also palms and soles are going to be typically spared in the adult scabies, and itching is going to be at the night time, and also mites are going to be 10 to 15. Infantile scabies, remember there can be vesicles and also nodular lesions in the infants, and especially in the infants, if you see the palms and soles having the vesicles, it is scabies. You should think of scabies. And also face can be affected in the infants because sebaceous gland activity is not yet there in the infants. Coming to the Norwegian scabies, remember the patients are not going to have any kind of itching, because of which the mites are going to be in millions in numbers. They are very highly contagious patients, and also the entire body can be affected with hyperkeratotic vortic crusted plaques in these patients of Norwegian scabies. This is very important differentiating point to remember. And what are the important findings, or we can say association with the Norwegian scabies? The patients who are immunocompromised because of HIV or chemotherapy, and also those who are mentally retarded or institutionalized patients, all of them are predominantly having a possibility to develop crusted scabies. Coming to the management, the first line treatment topical is 5% Permethrin cream, and it's drug of choice, safe in infants and also safe in pregnancy. Oral ivermectin is the first line systemic agent which can be highly effective, and it can be used in the cases of the crusted and also a refractory case of scabies. 1% linden, gamma-benzene hexachloride, benzyl benzoate, crotameton also can be used. Simultaneous treatment of all the close contacts is very important, and also because this can transmit through the fomite, so treatment of the clothes in the laundry is also very important. What is the treatment? Yes, it should be hot water which should be used to kill the mites. Coming to the pediculosis, lice infestation, it is due to the blood sucking lice, and we have three main species which can affect the human beings. So what are those? Pediculosis, Capitis, Corporis, and Pubis. Each of them are very important. So Capitis is also head louse, and it is Pediculosis humanus where Capitis. The presentation will be usually the child presenting with itching or the scalp, intense itching, and if you examine, there will be posterior cervical lymphadenopathy. Nits or X can be firmly adherent to the hair. This is very important. And how can you differentiate from dandruff, or which is a mild form of the seborrheic dermatitis? In the case of the dandruff, the flakes are going to be very easily removed, but whereas in the case of the nits, they are going to be very strongly adherent to the hair. They are not going to be easily removed. Okay, and it is very common in the school going children. Coming to the pediculosis corporis, body loves, pediculosis humanus where corporis. Corporis, wherever you see, it is related to the body, right? Here the patients are going to have pruritus and excoriation marks over the body, and they are going to be very classically attached to the seams of the cloth, and whenever they feel hungry, they are going to come over the body and they are going to suck the blood, right? And remember, these patients, they are going to be vagabonds, that is, they are going to be just wandering around here and there over the places. So that's why this condition is also called as vagabond disease. And remember, these patients are going to have very poor hygiene, and it is the organism is also a vector for other important diseases, like for example epidemic typhus, the relapsing fever, and the trench fever. important point from SPM point of view. Coming to the pediculosis pubis, the louse which is producing this looks like a crab, that's why it is called as a crab louse, and this condition is because of the thymus pubis. In the pubic region, there is going to be a lot of itching, intense itching will be there, but remember the infestation can also affect the thick hair, pubic hair, axillary hair, chest hair, and even the eyelashes. Very interesting, isn't it? The reason for this is because of the 69, right? Next is it spares the scalp hair. This is also important. Previously it was asked as a one-liner. And remember, because of the saliva which is mixing with the blood, there can be a bluish tinge to the skin because of the bite of this lice. It is going to produce this bluish discoloration, so it is called as a maculae ceruleae, and it is also considered as a sexually transmitted disease, right? Management is with permethrin shampoo, lotion, ivermectin for body lice. Very important point. The clothes need to be disinfected or they can be discarded. That is the treatment which you are going to advise. Next is migratory infective conditions which are going to penetrate the human skin, and they are going to crawl in the skin, leading to distinct serpiginous lesions over the body. Two of them are very important, the cutaneous larva migrans, which is also called as creeping eruption, and larva current, which is also called as a racing larva. So cutaneous larva migrans, it is the etiological factor is the animal hookworm. Remember, the human hookworm is not going to produce this condition, and Ankylostoma brasiliensis and Ankylostoma caninum are important for you to remember. Ankylostoma duodenale cannot, I repeat, cannot produce cutaneous larva migrans. Very important point to remember. And how is it transmitted? Basically during the barefoot walking in the sand, in the beaches, the larvae which are present in the animal excreta are going to enter the skin, and they are going to produce the serpiginous lesions which are very itchy. And also in the case of CLM, they are going to be slow pace 1 to 2 centimeters per day. Treatment albendazole ivermectin. Whereas in the case of larva currents, the etiological factor is Strongyloides stercoralis, because of which there are going to be urticarial lesions produced all over the body, because the spread is very rapid, 5 to 15 centimeters per hour, and ivermectin is the drug of choice in this case, right? Next, coming to the Leishmania protozoans, and they are going to be transmitted by the bite of the sand fly, which could be old world Leishmaniasis because of Phlebotomus, and the new world because of Lutzomia, right? Coming to the oriental sore or Delhi boil, so Leishmania major, Leishmania tropica are etiological factors. Presentation is going to be in the form of non-healing nodulo-ulcerative lesion with an indurated border and central crusting on the exposed areas of the body. Very characteristic presentation. And in fact, the ulcer at the center and the periphery raised margins will look like volcano. So this is also called as a volcano sign. Treatment, usually it can heal spontaneously, but we can use the pentavalent sodium stibogluconate and miltefosine as a treatment. Coming to the PKDL, post Kala Azar dermal leishmaniasis due to the Leishmania donovani occurs 1 to 2 years after the treatment of the visceral leishmaniasis, that is Kala Azar, if there is improper treatment, inadequate treatment. And Kala Azar, how is it going to present? It is going to present with a very important history of prolonged fever, and also patient will have massive hepatosplenomegaly. Very important points to remember. PKDL presentation will be with hypopigmented macules and papulonodular eruptions over the body, predominantly affecting the trunk and the face. Treatment is with oral miltefosine, which is the drug of choice for PKDL, right? And what is the treatment of drug of choice for the patients of Kala Azar? It is going to be liposomal amphotericin B. Very important to remember. If there are hyperpigmented patches over the trunk, they are important. Differentials which you need to consider, which are P. versicolor, the PKDL, and also lepromatous leprosy. How to differentiate? We are going to see in this particular table. So Tinea versicolor, Pityriasis versicolor, better term. The causative organism is obviously a fungus Malassezia species, Malassezia globosa and furfur, where there are going to be this asymptomatic recurrent lesions which are present over the trunk, and there is going to be this scaling which is called as furfuraceous scaling, which can be identified with the help of scratch sign. Sensations are normal, sweating is also normal. Coming to PKDL, the patients are going to present with a very important history of the prolonged fever, which is a finding for visceral leishmaniasis. Scratch sign will be negative, sensations are normal, sweating is also normal. Coming to the lepromatous leprosy, here the organisms M. leprae, we have already discussed Hansen's disease in a separate video. Okay, the links of the other videos of rapid revision dermatology are there in the description of the comment section. You can check them out. And also, if you are liking this video, please do that like button so that I will understand that students are actually liking this kind of rapid revision videos and also the dermatology related videos, right? Coming back to this topic, lepromatous leprosy, the scratch cell will be negative, but here the patients are going to have reduced or loss of sensation. Also, very interestingly, importantly, thickening of the nerves is going to be classical for lepromatous leprosy patients, and the sweating can be reduced, or there could be anhidrosis, complete absence of the sweating. So, few other important types of the arthropod infestations which you have to remember: the insect bite hypersensitivity or papular urticaria, which is because of the mosquito or flea bite, because of which there is a development of the allergic reaction, usually in the children who are having this allergic diathesis, that is atopy, presenting as recurrent pruritic papules, especially over the exposed body parts. Classically, the condition is going to worsen during the rainy season. So this is very important. One liner question. Myiasis, I hope all of you know, this is not Mia Khalifa, this is myiasis, which is infestation of live human tissue by the maggots. Here you can see furuncular lesions will be present over the body with central breathing hole through which the larva is going to take the respiration, breathing. Onchocerciasis, Onchocerca volvulus, black flight is used, what is transmitting this river blindness, and the patients can have the skin depigmentation, which is called as leopard skin, and it is treated with ivermectin. Filariasis, Wuchereria bancrofti, going to affect the lymphatic channel, because of which elephantiasis can occur, and here treatment is with DEC, diethyl carbamazine. Coming to another condition, which is rosacea, which could have an association with Demodex follicularum, which is basically a commensal mite that lives in everyone, especially in the hair follicles and sebaceous glands of the face, and overgrowth can be associated with the rosacea. So I hope this video was helpful. So please do the like button and also subscribe for more such videos on a regular basis. Thank you so much. If you have any doubts, you can put them in the comment section. Happy learning. We'll meet again very soon. Sarvam Sri Krishna Sarvejana Sukhino Bhavantu. Bye bye.